Hi, I'm John Hovanesian, and this is a Helio interview I'm doing with Jim Mazzo, an expert in our field who's led many companies, and we're going to continue our conversation about reimbursement and about changes in healthcare meetings that are happening after the pandemic. Jim, thanks for joining me.
Thanks, John. Looking forward to our discussion today.
Yeah, so this is the last of our segments, but we talked last about how practices are perhaps taking a pause from capital equipment, but thinking in bigger terms about any acquisition of a new technology as, measuring it based on how it's going to serve their ability to deliver more value to their patient. One of the things that has been one of the biggest costs in healthcare is drugs. And retina, of course, has been the specialty that has generated most of this. We're looking, as we look ahead at the next 30 years, leading to 2050, those costs potentially skyrocketing. And I'd like to get your impressions from the reimbursement side about how we address this. So let me start with this. By the year 2050, 1/3 of Americans are expected to be diabetic. Of those, 1/3 are going to have diabetic retinopathy. And of those, 1/3 will have diabetic macular edema, which needs treatment. And another perhaps 10 or 15% may have proliferative diabetic retinopathy, both needing drugs. That's just one diagnosis. We haven't even talked about macular degeneration. But the total cost of treating macular degeneration and diabetes may exceed $1 trillion per year if the drug costs remain the same and the rise in the population and the cost of drugs continues. How on earth are we going to afford this?
Okay, how much time do we have? Like 6 hours, and we can attack that by breaking it out. I would sit there with
questions would be easy, Jim.
I'll tell you, wow, this one is a tough one. But I think the answer is you gave a key word in that answer, and I think the first answer is diagnosis. We blame a lot on the cost of products. We blame a lot on the time, etc. And I think part of the problem is physicians are throwing darts at a dartboard, and it's easier to prescribe. Companies then take advantage and come out with products that maybe fit the need. I go back to something I say, John, you've been doing for years, is we need to diagnose the problem first. So let me break it down. First off, I believe back to my telemedicine again. Let's properly have the patient in your office that you need to spend the time on to really say, I need to diagnose this patient, both personally and with the proper instrumentation, and not have somebody in that's already been diagnosed. But more importantly now, and this is a little positive for Zeiss here, the only company that both diagnoses and treats, before you start treating, properly diagnosed. And I don't feel we have utilized the diagnostic equipment that's available to you across many great companies to identify what is the patient. You haven't had the time, nor have you spent the time. And I don't mean to personalize it because it's not true to you, but I see so many patients that have just not been properly diagnosed. And that's been the problem. So what do? You potentially prescribe, or you hope, or you delay, and then thus the increase in costs. Now, I will say, come back to industry. We can't continue to charge the type of drug prices. And you can see the current administration and whatever the next administration will be, they're just not going to be able to. And on a global basis, the cost of drugs cannot continue to be at the level. And one of the problems you mentioned was retina. It's not just going to be a drug. It's going to be a drug and device, like what's happening with neurotech, where there's a device associated with the drug. So I guess because we don't have a ton of hours here, I would sit there and critique ourselves as an industry that we're not diagnosing the patient first off. When you properly diagnose the patient, you're going to treat the patient. And when you properly treat the patient, actually, you're probably going to have a lot less waste in throwing darts at a dartboard. So that's the way to address it. Then number two, it's going to be incumbent on us. We're just not going to be able to introduce drugs that have that kind of price because it's just not going to be affordable or accepted by the current regime.
Yeah, and I think what we'll see is more responsibility shifted to physicians for the costs that they generate. And this is, not popular among physicians. It's certainly not something I like to acknowledge, but we have no, quote, skin in the game when it comes to using more versus less expensive drugs. And with an unregulated system, we tend to drift toward the more expensive drugs because there is incremental data that they work better. The old challenge in healthcare is if a product is 10% better, how much would you pay for it? So if you're buying a car, well, you drive a pretty nice car, so you might be willing to pay for one that's 10% better, but the average person, unless they're, choosing something that's a vanity item, and drugs are not vanity items, would not choose a drug that's 10 times as expensive if it's only 10% better. So
Right.
I'm suspecting that we're going to see some pressure on physicians. Maybe it's not financial responsibility, but ultimately it probably could lead to that, where we, are responsible for the outcome rather than and part of that is the cost of the care. So would you agree with that statement?
Yeah, and I think that you hit a nail on the head, and I also attribute that to diagnostics. I mean, a lot of times the practices don't see the value, the return on the proper diagnostic equipment. Yeah. And I would say really get the diagnostics done correctly. But we talked about it earlier, I think in segment 1, losing a good tech who used to do that diagnostic has been a problem now too, because you relied on that tech who was beautiful in doing the diagnosis and giving it to you. So it's incumbent upon us to continue to give you the right type of equipment. And then something else, John, that we kind of talked about, but you've actually done a fantastic, we need to provide more data. Having paper now to manage a patient is unacceptable. You just should not have paper to manage a patient because we know it just is unproductive. If we're able to provide the data, as you look through the instrumentation, you'll buy that instrument, you'll actually do the diagnostic, because then when you look through your scope and you're going to be doing an OR, you're in the OR and you're going to do an IOL and you have the information in your scope versus having to look at a piece of paper, you'll do it. So we have to make it more efficient for you as well. And as I've always said, he or she who owns the data will win in this cost containment environment.
I think you're right. So when you talk about diagnosis, having the instrument and knowing its best use are also important. I see a lot of anterior segment people who are terrific physicians who do OCT scans, but really don't know, for example, all the nuances of how to interpret and how to use that machine to learn everything they can. And usually we're talking about scanning the retina, and that's sort of not our home territory. And yet, how essential is it for us to do that well to serve our patient best? The other piece that I think is important, and I call it the third blind man evaluating the elephant. The old analogy of there's 3 blind men evaluating an elephant, and one describes the tail, and one the trunk, and one the skin on the side. They all see something different. Our third blind man is patient-reported input, because we are really good in ophthalmology at examining the eye. We're really good at biometrics, but we're not so good at psychometrics, which is understanding what's between the patient's ears, they're in their brain, what they're thinking about. And, I think and have some experience with this because I have a startup company, MDbackline, that focuses on this, that when we truly ask patients the right questions in the right way and organize the responses, we can learn a great deal about them. And about the disease that they're undergoing. We did a study,
Exactly.
And I'm going to tie this into education in a minute, which is our next topic. We did a study looking at the patient's perceptions of side effects of glaucoma drops. And for us healthcare providers, shortness of breath is probably the scariest side effect we could cause for a patient, because it usually means they're on a beta blocker and it's potentially causing their heart failure to become worse, or their lung disease. Well, for patients, shortness of breath from a beta blocker, even when they attributed it to the beta blocker, was not as important as stinging, as when their eye drops sting their eye when they put them in. And it's somewhat shocking, but if you step back from your role as a physician, where we often say, well, it stings, and so it goes into your eye. You know you got it in your eye, so just put up with the stinging. No, for patients, that may mean they may not take that drop. And so for us, the next step is to look at, let's take those patients who had stinging versus those who didn't, and look at what happens on their OCT of their nerve over time. Because we're almost certain that you're going to see less, them doing less well in terms of managing their glaucoma. So, Jim, that may be part of the solution, is ways of understanding diagnostics that don't cost a lot of money. Asking patients questions doesn't cost a lot of money, and yet it can yield useful information.
Right.
Any comments?
And John, to that point, John, you said something I would build on. I've seen practices do a great job pre, but don't do any post. Or they do post and they don't do pre. You have to ask the questions before and ask the questions after, like you do. Because pre gets you ready to diagnose and then ready to treat. Post is, are they following what you've been saying they're doing? You know, and that's where I think practices are missing, is the pre and the post. And you don't have to do it in your office. Today's mediums can do exactly what we're doing here, virtual. They don't have to be in the office. And that's why I think this whole telehealth is a really good medium for you to manage that patient pre and post.
Yeah, and when we say telehealth, what we're talking about here is asynchronous telehealth, where you're asking questions of a patient, but it doesn't require a live staff member or a live doctor talking to them. It can be done with a survey of sorts is, can be the same thing. And I think one place we need to get, particularly with premium IOLs, is to demystify how you can have success. We have a pretty good idea on an OCT or a corneal topography what makes a good, refractive IOL candidate. But what about, with what's in their mind? What are the questions and responses? And then let's pair that together with the biometrics. And then let's look at how happy they were after surgery to say, what's the ideal pattern? The ideal patient, if you see a patient with this history and these biometrics, you put in this type of lens, here's how much success you're going to have. You're 98% likely to have a very satisfied patient. I think we need to give doctors that kind of background, that kind of step-by-step approach to be successful, and to have more doctors really using premium IOLs.
I agree, John.
So let's talk about meetings of the future. Last time we talked, I asked you this question, and we both kind of pondered, but didn't really know. So what have we learned since the shutdown? We've been to an ASCRS meeting, and there's been OTS and a variety of others that have cropped up. Some companies have sponsored meetings very effectively. Hats off to Zeiss, who I think has done a great job with this. But Alcon and others have. J&J has put together some terrific educational content. What's going to change? What do you see, not only in the next year, but beyond in meetings?
Well, I'm going to this is first off going to be a 40-year veteran that's probably a little more biased. I still am concerned we're losing that social interaction. I truly believe that the hallway meetings, the side conversations have built more industries than anything else. So I am a little concerned that what's going to be the future is the lack of these social interactions. But saying that, we still need to have an academy, an ESCRS, an ASCRS. We still need to have these large meetings because you're getting valuable information that you cannot get because you're so overwhelmed in your office. And those will still need to be. The question is, do they need to be as long as they've been? And that's, I think, a change. So let's start with the meetings when they do come back. I don't think your need to have to be as long. I think these subspecialty days have been very successful. They will continue, and I think the length of the meetings will be less. Number two, I think regional meetings will become more popular because people aren't going to travel. So you're going to see more of the regional meetings in the various geographies across the world be more attended, and thus less global attendees at one major meeting. So I do think what's going to happen is shorter, longer, bigger meetings and more regional meetings. But while we're getting to that, this virtual has shown that you can clearly communicate when you have a captive audience. Now, you're back to practice. You're busy. I'm going to have to, if you're going to look at it, it's going to be more on a recording standpoint than actually sitting for 4 hours to watch a virtual meeting. Before we had you, you weren't practicing. But now, are you going to sit on a Saturday and a Sunday and watch where you've been away, you know, working hard and now taking away some of your personal time? I think that's going to be a challenge. So I think what's going to have to happen is a much more impactful recordings that you will be able to watch at your leisure versus sitting. And then I think it's going to be more incumbent on companies to make sure we're aligned with that impactful information around telemedicine, how to improve efficiency. Just having the typical, here's the greatest new device, probably not going to work anymore because I just don't have that captive audience as I used to. So long-winded answer, large meetings, shorter in time in the future, regional meetings, and less people coming across geographies. And then these virtual meetings have to have really some short content. And I think OSN is going to show us that in the New York meeting coming up. That it's going to have more around efficiency. So I think things like that are a way to go in the future.
Yeah, and you know, I know you'll agree with this. Hard-hitting content is, you know, meaning really sort of telling it like it is. We have a meeting actually called that. Bobby Osher was onto this before the rest of us. Is going to be essential, isn't it? When you're going to go to those meetings, you want to walk away feeling like you really have something that you can take back. It wasn't just, hey, I had some nice dinners in New York City. It has to be really valuable content, doesn't it?
It really does. And it's going to be with us for a period of time that people are not going to be willing to travel. There is no doubt. This is not just a 2020 phenomenon. I think we're going to feel it next year too. We might have the meetings, but there are going to be less attendees. There's no doubt. And that's why these regional meetings will become more important because people are more willing to drive or have short distances to go than across major geographies to travel to get to a meeting.
Right. You know, and I think it's a little bit, meetings, there are a lot of different reasons people go, but we have to think about the need state of the person who's coming. You know, so if you're just coming to get CME, you may be less choosy in the content. You may choose based on how many hours you're going to get for, you know, and how easily. But for a lot of docs, there's a specific reason. They'll go to a meeting saying, look, I want to, you know, I had a tough case recently, and I know I've got more coming up with zonular laxity. I want to get really comfortable with all the techniques to address this specific problem. And so, you know, live meetings can address that, but I suspect this will be a really nice niche for virtual meetings where, you know, you'll have an hour-long virtual meeting put on, you know, by a company who recognizes there's a need for this education. And you can talk a little bit about technology, but it really needs to be about what the surgeon needs to know. I want to walk away feeling like I now have 3 more tools I can use, not just mechanical tools, but just ideas and how to manage this problem when I see it. Or maybe it's, you know, we'll go back to reading an OCT, something that's going to genuinely improve the surgeon's confidence in doing their job. You know, if you can offer a meeting and do it in an hour for that, I think there's an audience for that, don't you?
Well, and actually, yes, I agree 100%. And I'll say something you said earlier. This is actually an opportunity for a smaller company to be very successful. When they went to the large meetings, smaller companies just couldn't outman the large companies. You know, you had to make a decision, Dr. Hovanesian, where you wanted to go. You know, you just couldn't be in 3 different places. And, you know, the large companies provided a greater benefit for you to see a plethora of products, right? Right. Now, a smaller company can probably get your attention a lot easier. So actually, interesting enough, these virtual meetings are going to be better for smaller companies than the larger companies.
Yeah, there's few barriers to entry. It's just a matter of getting the word out. And yet, if you've got the right content, it's clinically oriented and it genuinely helps a doctor, then more power to you. You should be very successful.
Exactly.
Well, Jim, before we sign off, I want to ask you one last thing. How are you spending your free time? You're not, you know, globetrotting like you used to. You recently retired as the head of Zeiss globally for Ophthalmics. What are you doing with your free time?
Zoom. No, you know, so the answer is I still love our industry. I'm still very involved in our industry, everything by being on the ASCRS governing board and participating with the American Academy and iAccelerator and Octane. But I'm also working still with Zeiss as an advisor. with about 5 other ophthalmic companies and a couple non-ophthalmic companies. So I'm still very involved. I love being involved with people like yourself and with OSN and other entities. So I'm sorry to say, but you're not getting rid of me. Ophthalmology is very important to the Mazzo family, and I'm going to stay continually involved with both the large and the small companies and doing more of these, but also learning. It's been fun to be part of some new technologies in retina that are coming out where I get to learn more and more. So just spending time differently, not less. But it's always good to see you, John, and I thank you so much for this opportunity, because it's great to hear from you and have this opportunity to talk about what's happening in our industry, and then 3 months from now, see where we were right and wrong. That's always fun too.
That's always the proof in the pudding. Jim, well, I'll echo your comment and say that the Mazzo family is very, very important to ophthalmology as well. So we, you know, I'm very grateful to you for participating in this. You've got a new grandchild, I understand, who you'll be able to see soon. Is that right?
I do, yeah. In October, my son Chris will have his second. Yeah, that'll be number 5, which makes it even more important to keep busy, because I got to keep it going to keep more grandchildren employed.
That's right. The patriarch of the family. Well, Jim,
Yes,
thank you very much. Thank you very much for spending this time with me. And I know I learned a lot, and I hope our viewers will as well. So this is John Hovanesian. And once again, thanks to Jim Mazzo for participating in this OSN interview on the future of the ophthalmology industry. Thanks for watching.